What I want to deepen now is, and we talked about it a bit, hypertension. Did we talk about it or not? Not yet. Hypertension. I mean systemic hypertension. So that means like normal pressure is how much? 120/80. You know that the diastolic, then if you go deeper into the small arteries, there's a continuous flow, so you don't measure like two of them, but it decreases like gradually. But the question, the most important question, I'm having hypertension. Will I have edemas?
Yes.
It depends. Okay, I'm having only hypertension. Will I have edemas?
You can, but not always.
When will I have edemas?
When
When
the
the
pressure is
hydrostatic pressure is greater than the public.
Okay, that's a very clever answer, very general, but when this happens? Okay, that would be, but we're talking about that the cause is hypertension now.
Higher systolic pressure in the right heart, like in the ventricle.
Okay.
Above 20, like for lung edema above 30.
Okay, you're talking about, but I'm talking about systemic. And it doesn't need to be like if you have increased pressure in pulmonary artery, that you don't have to have edema. Okay, depends what's the cause. So okay, guys, remember if we're talking about systemic hypertension and only hypertension, there's no edema. And why? Well, exactly. So and precapillary sphincters are protecting the capillaries against this high pressure. So the pressure is between the precapillary sphincters and the left ventricle. That's increased, but not behind the precapillary sphincters. And you're right, arterioles play a role in it as well. And basically the tissue is sort of auto-regulated that the pressure in the capillaries is not increased. And mnemotechnically, how you could remember that there are no edemas in hypertension, like solid hypertension, or that if the patient has only this problem is, what do you call it? A silent killer, doesn't it? If I would have edemas immediately, it wouldn't be so silent. And typically I'm having hypertension for several years before I will start to have edemas. And we'll talk about it just now, but wait a sec. So, I'm going to draw a bigger heart here. Okay? Like that. Bifurcation here, and another one, whatever. Okay. The green will be capillaries, and blue is going to be, guess what? Veins. And these will be precapillary sphincters here. So if I'm having hypertension, like here, 180/120. The pressure is, of course, in aorta and in the big vessels, it's going to be pretty the same. It's going to be 180 over. But if you go deeper into the smaller arteries, it decreases. But it's increased compared to normal. But you won't have edemas. So, and why is hypertension so dangerous? Because it's silent, you don't know. I mean, if it's too high, then you're going to have some headaches or whatever, but normally you don't know. And there are many, many reasons why it is dangerous, but first of all, you should remember that hypertension always speeds up what process?
Exchange.
I'm sorry?
Exchange.
No, one speeds up one pathological process. Okay, we're getting there, but
Atherosclerosis.
Yes. So very much. There's a shear stress, like there's higher pressure in the pipes. This speeds up the atherosclerosis, so you're having atheromas everywhere.
Why?
Microangina.
Hey, that's $1 million question, but it's like that. We're trying to find out why. But let's say they're more stressed, the endothelial cells, by the tension increase, and as the water, like as the blood flows, it like changes their shape in a way. That's the shear stress, and this initiates some kind of inflammation in a way. But of course, it's much more complex. But again, why is a question for some deep science. You don't have to know that. Just remember, there's atherosclerosis. Okay. So we know the atheromas are like appearing more faster with hypertension. Okay. So your pipes are getting rusted faster. Another disease. So hypertension is one problem. Another thing which really speeds up atherosclerosis is what? So hypertension, and these work together very likely. One endocrinological disease like almost everyone has. Okay, well that's like different cup of tea, of course, but what is the one? DM. Okay, so diabetes mellitus. Remember, these two, they alone or together, they really speeds up the process. So remember that. If the glycemia is high, you are getting older within your pipes. And the thing you should understand is that also these arteries are getting rusted. Okay? Yep.
If the heart has to pump against a higher pressure, a higher systemic pressure, wouldn't it also cause like an overload?
Yeah, we're going to come to that. So first we're talking about atherosclerosis. So basically everyone who's older and with hypertension, you should imagine how the vessels are awful. Not in your cases, but let's say much older people than I am will already have really rusted, awful pipes. Okay? So atherosclerosis, that's one problem. The other one is with hypertension. There are many other, of course, all other organs are not doing fine, especially kidneys. Remember, they're like the glomeruli are destroyed by this increased pressure, and they're not doing well. And basically, what we say is that kidneys, maybe they make up the threshold, as we learn now, for the hypertension. Okay, normally the pressure should be 120 over 80. If it's 130 over 90, it's a problem, okay? Or it starts to be a problem. Anyways, because there's a increased resistance within the aorta, because there's a higher pressure, of course it's just the same for heart as if you would be, lifting up weight. So what happens if I would be lifting, if it's left arm, so this one is going to get like bigger, isn't it? So that's why the heart gets bigger, thicker at the beginning. So you have hypertrophy of the left ventricle. Okay. So if you cut the heart like that, if you cut the heart like that, then what you'll see is, or I won't be showing the cuts, but so this is left ventricle, and it's getting thicker and thicker, okay? It grows up, okay? But the problem is, this is cut through the ventricle, but the problem is that the arteries, I should delete this, the arteries, which are supplying they come from outside, they go deep into the muscle, they're not getting thicker. Okay, they're getting thinner in a way, or they're not expanding in any way. Okay, so basically within the years you have more muscle to feed, but with the same or even worse pipes, because again they're full of atheromas. Okay, yeah. And the disadvantage of the heart is that actually, if I'm having a muscle here and I start to work with it, then there's a command to my brain, whatever, that the heart should pump. Okay, that's fine. But what about the heart itself? It gets thicker, and every time it needs to work more. Like there is this discrepancy, okay? Because first of all, the vessels, I didn't get more vessels in the heart. Only the muscle got thicker. So there's more mass I need to support with oxygen and nutrients. But also, the lumen of the coronary artery is getting smaller because of the atherosclerosis, okay? So typically when I'm having, when there is a blockage more than 60%, I start to have ischemic attack when there is an increased load, okay? Yeah? When the heart starts to pump more, I'm starting to having ischemic attacks. And this is what you call angina pectoris. And you can check the videos on ACS, acute coronary syndromes, and you got everything over there. And that's a very important lecture. You have to know that. But anyways, so I'm having narrower coronary arteries. And now look at that. There's an increased demand. I'm having tachycardia because whatever the reason. So what happens? The heart pumps more and it needs more perfusion then. But now I'm having these thinner, smaller arteries. So I'm getting much easily ischemic. It's such a disadvantage of the heart itself because when I'm, when I want to support the muscle over here that I'm working, okay, fine. Heart will somehow bring more blood over here, okay? But the heart, if I need more blood into the heart, the more I need blood from my heart, I need to force the heart to more work. So it's sort of this vicious cycle, okay? It's like overloaded twice, if you get my point, okay? That's the problem of the heart because it's the engine, okay? And the engine, it needs its own cardiac output to increase its own blood flow, okay? So where I'm heading is that when you're old, you don't want to have tachycardia. Why? Because you're increasing risk of ischemia and MI, okay? Yeah? Because also when you're running the blood fast through these awful pipes, it happens that they will crack. The atherosclerosis will crack, rupture. You will bleed into it, and the thrombocytes will sit there, and you will have a thrombus over there, okay? But you don't have to have thrombus. If it's narrow enough, you can have an ischemic attack. But the problem with the heart is you cannot turn it off so well. So even if I'm having a narrow coronary artery, and the heart will work over the pain, I will have MI. Or I can have a blockage right away and having MI. Okay, it depends. Check the ACS on that. But anyways, so I told you something general. I don't want to have tachycardia too much in old patients. Okay. Okay. And now, of course, you will know the answer. If I ask you guess on what the patients with anemia will die if they're old. Am I? Because it's like putting them on a treadmill, but we cannot turn it off. Okay? Yeah? Because they're having anemia, there's this compensatory reaction, so they're having tachycardia. And the same is what will happen if they lose a bit of blood. Again, tachycardia, they can have MI because either it can rupture, the atherosclerosis can rupture, or only it's narrow and you will have ischemia of the heart. Because heart works faster, it has a higher load. So anything that loads up heart can cause MI at the end. So guess what else? Why we had this epidemic of something for 2 years? COVID. Okay. So what does COVID do? ARDS. Okay. So you're having ARDS. I'm not talking about that it's triggering also, of course I know that it also induces endothelial cells and whatever, and there's a cytokine storm and whatever other ways how to trigger a thrombus formation, okay? But if you just take it from the perspective from the lungs, again, the compensatory reaction, because I'm failing with oxygenation, so the compensatory reaction is increased heart rate. So that's why Okay, so always be aware if an older patient with something that the patient has something with lungs or anemia, always be aware he could die on MI, okay, very easily. In general, or if it's bleeding again, every time they have tachycardia, and the people with anemia obviously have tachycardia, they can die on that. So what will you do immediately when someone like 70-year-old lady comes and she has tachycardia? So what will you do? How can you stop the heart? Like very fast, how can you calm down the heart? Okay, but will you solve the anemia somehow, or I mean like
Just a symptom.
yeah. So of course beta blockers are important, but can you turn it off like functionally somehow?
You can give more oxygen.
Yeah, exactly. You give more oxygen. Okay, so if you give more oxygen, higher concentration, although you don't have erythrocytes, you will physically dissolve it into the 1 liter, and that's how you will calm down the heart, because now the blood is able to bring more oxygen in 1 liter than before, so you can slow it down. And it's the same with COVID again. If you had ARDS and you had a saturation like below 93, they give you oxygen to slow down the heart. Okay? Yeah. So always think like in this way, I'm actually trying to protect the heart. So every time someone old comes and has tachycardia, watch out. It can lead to MI very soon. Okay? And many other things, but you should understand the principle of MI. Okay? And again, as the blood flows fast through these awful coronaries, you can, like the flow can rip off the, or crack the atheroma, and you're having heart attack. Okay? So that's why I should calm them down. Okay? And painkillers, whatever. Anyways. So, thanks for watching. And don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.